My name is John Drezner. I'm a team physician here in Seattle, Washington. Take care of the Seattle Seahawks, Seattle Reign, and some of our university athletes. I'm also the director of the UW Medicine Center for Sports Cardiology. These are my disclosures. I work with a couple companies and advise on ECG interpretation in the young. I'm currently editor-in-chief of the British Journal of Sports Medicine, and we'll see some papers from that journal. I volunteer for several local or national foundations dedicated to the prevention of sudden death in the young and have research funding from the National Center for Catastrophic Sports Injury Research and the American Heart Association. We're all aware of some of the high-profile cases of sudden cardiac arrest that have occurred, cases like Christian Eriksen, Damar Hamlin, Bronny James. But as we know, it's not just our high profile and professional athletes who can have sudden cardiac arrest. SCA is the leading cause of sudden death during sports and exercise can be a trigger for sudden cardiac arrest in athletes with an underlying heart condition. A quick stat from our data, 75% of all fatalities during sports are cardiovascular related. So, as a primary care sports medicine physician responsible for the health and safety of athletes, this is really my first and most important responsibility. As I reflect on the field over the last 20, 30 years, for me, sudden cardiac death in athletes really came to the forefront when I was at university and also in medical school with several high profile, sudden death cases. It's really important to think what we've learned since that time. Sudden cardiac arrest is not so rare, not like I learned when I was in medical school. The history and physical is simply not enough for cardiovascular screening, and precision ECG interpretation is possible. AED should be everywhere, yet still sudden cardiac arrest can go only about 20% of athletes who go on to have sudden cardiac arrest have warning symptoms. So if our evaluation is based on identifying athletes who have potential warning symptoms, we've already missed the majority of individuals at risk. We started screening with ECG routinely in 2010 at the University of Washington. This was just our initial cohort, 800 athletes. You can see that 37% had a positive history response, 3.5% a positive physical exam like a murmur, and only 2.8% back then considered an abnormal ECG. We identified 5 individuals with conditions at risk for sudden death, one with HCM, one with long QT, and 3 with WPW, all identified because of use of an ECG. If we had done history and physical alone, we would have missed all of those cases. Kim Harmon has done great work in this field, and this was a systematic review and meta-analysis published in 2015. Over 47,000 athletes included. ECG was 5 times more sensitive than history, 10 times more sensitive than physical exam. A lot of times we're asking, like, when do we start cardiovascular screening? Recommendations are generally, starting at age 12 and every 2 years after that. But when should we really be doing it? And this was a really a terrific study from our Italian colleagues, a cohort of 22,000 young athletes who had serial investigations, including ECG. And you can see that after the age 11, beginning about age 12, was when the yield really picked up. The yield for cardiovascular screening increased, and that's probably because of the phenotypic expression of some of the conditions that we're looking for that occurs during adolescence. So in the US, we continue to have this big gap. On one side is generally what's occurring for high school and younger athletes, just a history and physical model, often with the primary care physician. And on the right of the screen is really what's considered best practice, history, physical, ECG well interpreted, and cardiology resources to help with downstream investigations. And this is part why we're spending a lot of time on education, training, and trying to grow that infrastructure to bring better screening for the same exact purpose, to more individuals. This is now considered best practice in this consensus document published by FIFA on how we should screen youth soccer players. And even the American Heart Association and American College of Cardiology, in their most recent recommendations, recognize the additional value of an ECG when it can be appropriately implemented. And in this particular document, they recognize that a 12 lead ECG screening is reasonable as long as it has equitable access to the downstream process with appropriate resources. And although the history and physical has a relatively low, and they recognize that the history and physical has a relatively low sensitivity, 10 to 20%, and that ECG enhances detection up to 94% in their stated document. We had a whole workshop on ECG interpretation in athletes yesterday. I hope many of you were able to attend. And we have successfully lowered the false positive rate while maintaining the sensitivity to detect the conditions that we're looking for over the last couple of decades. There's been this evolution of different ECG interpretation standards, beginning with the European Society of Cardiology recommendations in 2010, the Seattle criteria, the refined criteria, and the international criteria published in 2017, all successfully lowering the false positive rate but maintaining our sensitivity. If you're not familiar with the international criteria, this is the published diagram from 2017, and I encourage you to go back to that workshop and understand its use and application. As you know, this past September, we hosted the International Summit on ECG Interpretation in Athletes right here in Seattle to update the international criteria. This is coming soon. This is a draft of that central figure. And again, I'm expecting publication hopefully in September